I'd like to invite now Dr. Jeffrey Liebmann to speak on visual field for diagnosis and progression. Dr. Liebmann is Vice Chair and Director of Glaucoma at Columbia University.
Thank you, Gus, and congratulations to Elena and Greg on the 40th anniversary of the Glaucoma Foundation and for really expanding its role in the glaucoma community. Here are my disclosures. None of them are particularly relevant for today's talk. There's some basic principles in ophthalmology and in glaucoma. This is from the World Glaucoma Association Consensus Series that's chaired by Bob Weinreb. The very first one that stated that a method of testing visual function is critical for the diagnosis and management of glaucoma. I also point you to this basic course called Forge, which was something that we created, Bob Weinreb, myself, Jack Chaffee, and others, looking at visual fields. And in that Forge series, which you can obtain online, you can learn about the fundamentals of perimetry, how to interpret a visual field test. If we wanted to do that this morning, it would take us the whole day. However, there are some caveats here, and this is from that same World Glaucoma Association Consensus Series, that perimetry, the way we do it, is not great for diagnosis of glaucoma. And this test pretty much is unchanged for the past 30 years. Over the past 30 years, you seat the patient at the machine, you put the patient's head in a bowl, you ask them to press a button when they see a flash. The doctor says, well, this is a poorly reliable examination. And the patient says, I hate visual field testing. Why can't you come up with a better test? Perimetry, and this is how it's performed. I assume everyone in this room has had a field. If you haven't had a field, you need to perform one immediately on yourself to understand what the patients are going through. There's a learning effect. It's very time consuming. Hopefully there are new technologies coming around the bend with using virtual reality and other things that might help us. Remember, perimetry was largely halted during COVID. I'm not sure that mattered all that much to our glaucoma patients. Just another caveat, in the OATS trial, we learned that most changes that occur in a visual field time to time are not repeatable. You must repeat this test to make sure that the finding that suggests change is repeatable. All that being said, what are the potential uses of perimetry? They're listed here on the left for diagnosis, structure function corroboration, monitoring. Some people have advocated screening. We all need it for disease stratification when we do ICD-10 coding. And what about the real world? Who should undergo perimetry? What algorithm do we use? How often do we do it? How do we analyze it? I'm going to just try to address some of these questions, not all of them. But can we use perimetry to diagnose or screen for glaucoma? I mentioned earlier that that's difficult. This is a slide that's an image that's over about 50 years old from George Spaeth, in which he described the cadence of glaucoma, where the disc and what we would now call the retinal nerve fiber layer also changes before the visual field starts to change. So if you're going to rely on perimetry to diagnose this disease, you're going to miss probably half of the early disease. And only at a certain point in time will the visual field progress along with the optic nerve or retinal nerve fiber layer. That was 50 years ago. More recently, of course, and this is an article from Weinreb and Peng Ka, looking at visual field change in the glaucoma continuum. Again, only about in the latter part of the disease process do we see the visual field change, whereas if you're looking at the optic nerve and retinal nerve fiber layer, you can detect the disease much earlier. Okay, thank you. So we really can use the perimetry to diagnose the disease or to screen for it easily. Can we use it to monitor glaucoma? There are really two groups of patients, those with normal visual fields and those with established visual field loss. Those without visual field loss are better managed with imaging. Here's a patient from the OATS trial, followed for 23 years with 46 visual fields, all of them pretty much normal. Maybe the last one is beginning to show some signs of change. That's a lot of testing, giving absolutely no information. This is a slide courtesy of Christopher Leung in Hong Kong from one of his papers, along with Bob, just demonstrating that in the second row, neurofiber layer loss occurring way before detectable visual field changes. And we see that all of us see that on our clinical practices. There's many different ways of looking at that, and David's going to talk about OCT, and you can look at the neurofiber layer, the ganglion cell layer, and so on. But getting back to perimetry, how can we monitor patients over time? This is a patient this is via the Forum platform, but it shows change over time. You see the two baselines in 2017 and 2018 for each eye, and the most recent visual field down below that was taken fairly recently. This patient has a slope that's different, obviously, in either eye. The right eye seems to be progressing more than the left, which is pretty stable. And the blue triangle is the COVID hiatus in care that happened to this patient, didn't come back for 4 years, and had progression in that right eye during that time. There's a lot of information that you can obtain from these types of analyses, looking at mean deviation and the rate of change over time. The average glaucoma patient changes at a rate from work that Gus did and others at around minus 0.2 to minus 0.3 decibels per year. This patient is progressing rather quickly at minus 1.4 decibels per year. Right eye compared to the left eye, and the right eye is essentially progressing fast, and the left eye is not progressing at all. There's a lot of other information you can glean from this. Glaucoma is a local disease mostly when it progresses. Eventually, it all looks like it's bad, but the disease progresses more focally rather than generally. And here you can look at the superior rate of change or the inferior rate of change. You can see where in the field the disease is progressing. You can also modify the way these analyses are performed. These red arrows are in a patient who had surgery. So after the surgery was performed, you can reset the baselines because you want to know if the patient's progressing since the time of surgery. You can see the rate of progression here is reasonably slow after surgery in this patient. And here are those rates of change, which can also be calculated for the central 10 degrees of visual field. So you can look at 24-degree analyses, 10-degree analyses, and get real data and numbers from your large sets of visual field data. Remembering, of course, that you need 5 visual fields in order to generate this data. It's important to get enough information to evaluate the patient. Just a different way of looking at some of these analyses over time. So you can look at the inferior and the superior rate of change for each patient. For many of these patients who have very advanced disease, it's important to monitor both of these functional aspects, the central visual field and the peripheral visual field. But even if it looks originally as if the rate of change in the 24-2 looks pretty stable, in this patient with very bad disease, the central visual field is progressing at a rate that's too fast in the right eye to preserve that small amount of remaining visual function. This patient has a pressure of 9. So if you have a good idea about how to take care of this patient, let me know. Of course, we can combine structure and function together and look at those analyses all at the same time. You perform corroborative analysis of the field and the OCT just to confirm that the progression is occurring. And of course, there's ample information about this in the literature. This is another consensus meeting from 2011. These are fundamental basic principles of progression. An interesting question is, can we use structural testing to decide which visual field test to perform? You can't perform a 24-2 and a 10-2 visual field on every visit. But that structural information that's available to us now will allow us will point us in the direction of which type of field might provide better information. A lot of this work is from the laboratory of Don Hood at Columbia. Gus worked on that and many others over time. And we know there's excellent structural corroboration between macular and retinal nerve fiber layer function. And if we do a ganglion cell layer image, as David will show you in a moment, it corroborates very carefully and closely and nearly perfectly to the visual field damage. And the structure function correlation with our current instrumentation is very, very precise. So you can look at a patient like this and not even do the field test and ask this question: does the patient have glaucoma? We usually ask all the questions on the right about family history and so on, but you really don't need to do that. You know, if the nerve's not pale, there's very few other things that this could be. So how can we make the best use of functional testing in the real world? Well, we got to leverage that structure function relationship. Again, for the residents who might be watching, these two articles out of the Hood Laboratory describe the precise nature of that relationship, both in the macula and the periphery, looking at ganglion cell layer and retinal nerve fiber layer. There's a lot of information that exists about the relationship between structure and function and how they change over time. And we, of course, have many ways to corroborate that level of damage, looking at the optic nerve, mostly with imaging, and visual field testing, and as it's currently performed, mostly with, automated white-on-white perimetry. But there's other ways to do corroboration. You can corroborate the disc change, topographical change in the disc with retinal nerve fiber layer change. That's also another corroborative method. Hopefully, Dave will show that to you. So here's how I think about perimetry today. I kind of think about the situation. Is the perimetry useful? How frequently should it be done? Is OCT useful? And what should the frequency be? And, for things like screening, perimetry is useless unless you want to screen for advanced disease, which may help you find people at greatest risk for blindness, but probably not useful out in the community. For a glaucoma suspect, we do a visual field, but if a field is normal, there's no point in doing an excessive number of visual fields. You're much more likely to find change in an OCT. If you have an early glaucoma in a normal field, the field's only useful to confirm the normality of it. It doesn't really provide you any information regarding change, but the OCT does. And, we perform OCT every 6 months or every 12 months in many of these patients. And actually OCT every 6 months for moderate disease and advanced disease is probably the optimal amount of work, optimal frequency. A lot of that work also done by Gus. When you have patients with moderate disease, established visual field defect, then you really have to begin to more intensively use perimetry. And certainly when they have advanced disease, a lot of our decisions wind up being made on the basis of perimetry. And a lot of surgical decisions are made on the basis of perimetry and parametric confirmation of parametric change. I mean, not many of us want to operate on someone just because the OCT changed by a smidgen. So with that, I want to thank you. I look forward to some questions later.